Okay, we are recording now. Let's see if I can get it to work well with the share screen. Okay, so this is lecture 1 for gerontological nursing, Nursing 3230. In this lecture, I will cover chapters 1, 2, and 3 and part of chapter 4. These are the learning outcomes for the lecture. I'm not going to read them to you, but these are the things that I will cover. So the word gerontology, you may be used to hearing the word geriatrics when we think about older adults. Gerontology is a term that is more inclusive or holistic and really includes the study of the process of aging and those issues that older adults face that could be physical, mental, and also social. Again, it's more of a holistic term. The prefix geron means old man, so that's where the word comes from Greek. When we say geriatrics, we think more about that being used for the profession of medicine, and that is more focused and deals with the diseases and treatment of older adults. So what is an older adult? Well, it depends on who you ask. So the World Health Organization says that older adults are people who are 50 and older, the UN 60 and older, Western countries, us, we say 65 and older. So for the purpose of this course, an older adult is a person who is 65 or older. Well, most people live well past 65. So we then classify older adults into these categories: the young old, the middle old, the old, and then the elite old. There are more terms for people who are over 100, and I'll review that in a minute. So these are subcategories of older adults. You don't exactly have to memorize this, but just understand that we classify these people because they're very different. So think about a person who is 66 years old. They're going to look and have very different problems, very different needs than a person who is 100. Those two people are very different. So here are some examples of some famous people that you may recognize and may not think of them as older adults, but everyone on this page is an older adult. They're all over 65. Like Oprah, look at this picture of her. She doesn't look 65, but she is. A lot of people will use the term or the saying, age is just a number. Well, it is. Now, that's one way that we measure age, simply by how old a person is. So that's the chronological age. And the reason people say, well, age is just a number, and that's because there is also more components to age. It's the age of the body, the organs, psychological age. Some people are mentally young, and some people are mentally old. So it's kind of how they feel. How old do they feel? A person with more or with strong relationships, intact roles in society or within a family or some sort of personal unit, they're probably going to feel a bit younger. So they are socially young. So really, the only objective measure of age is chronological, but the other measures of age are subjective. So I look at this information every once in a while to see if they update it, but still we're looking at kind of data from 4 years ago or so. About 50 million people in the United States are older adults. That's a lot of people, about 17% now of the population, depending on what reference you look at. That's about 1 in every 8 adults. And 10,000 people every day turn 65, every day. And the generation that is currently transitioning into older adulthood is the baby boomer generation. as a cohort, if you will, of people age, the ratio of men to women changes. And the reason for that is because women live longer, right? Women just live longer than men. They have a longer life expectancy. So as a cohort of people continue to age, it will have more and more women. So 2030, it seems like a really long ways away, but it's not. It's only 10 years. We're expected to, or projected to have around 70 million older adults within the next decade, and it will be a huge portion of the population. No longer 1 in 8. It'll be more like 1 in 5. And by then, all of the baby boomers will be older adults. We're expecting in about 15 years that there will be more older adults than than children in the United States, and it will be the first time. The younger generations are not growing as fast as they once did. And also over here on the left, I forgot to mention the fastest group of older adults, the fastest growing group are those who are 85 and older. The reason for this phenomenon is simply that people are just living longer. And also, once a person gets to the age of 85, they're probably pretty hardy and strong. And so there's a good chance once a person gets to 85 that they will live a good bit longer. Just some statistics here about population based on race or ethnicity. So for instance, looking at this chart, we would say maybe the Hispanic or Latino population, here's the total number, 57,400, and that's about 17% of that. Under 65 and older, so there's a comparison there. And it shows you here how the numbers change as we go up in age, right? So just you can see comparisons there. All right. This is a graph from the census, and it shows how the population of our country is very different than it was in 1960 even. So that was what? That's 60 years ago. And it's projecting 100 years after that. So we're somewhere in the middle right now with that, if you will. And you see in 1960 how we had the widest part of this graph with regard to population and numbers was younger people. So there were lots of children in comparison to older adults. So you see this tiny little population up here. But this graph is starting to flatten out, if you will. So then it's projecting how this will look. And do you notice here how the top of this chart, it's wider. So the 85 and older over here is wider than the other, most of the other groups of older adults up here. And again, that's what I was just saying, that those who are 85 and older, it's the largest growing part of the older adult population. So about older adults, most older adults, about 3/4 of the majority, suffer from or have at least one chronic medical condition, if not more. The most common chronic conditions in older adults are osteoarthritis and hypertension. Older adults utilize more health care than any other part of the population. A couple of social things about many older adults. Again, women live longer than men. Most couples are men and women, so therefore we will see older women who are often widowed by their husbands. So over a third of older women have had a spouse who has died. And that often leads to older adults living alone. Many older adults live alone, but it's most likely to be women. We used to think about older adults not having high levels of education, but that's changing. Maybe even some of your grandparents or great-grandparents may not have even graduated from high school, may not have graduated from 8th grade, and it was common, you know, for people who were born in the teens, 20s, 30s, 40s to maybe not prioritize education. However, older adults, the people who are turning into older adults now, like I said, are the baby boomer generation, and they are the most educated older adult population that we've ever seen in our nation's history. Well, that translates to they're a little bit more demanding, and they have a lot more knowledge, and they know how to research things and look things up. So often they will challenge us as healthcare professionals and expect more. I don't see a big problem with that, but it's just what we're seeing. There are fairly high rates of poverty in older adults. Older women are more likely to live in poverty. The highest poverty rates in the older adult population are older Hispanic or Latina women if they live alone. So that is a big percentage there. Just a quick review of what poverty means in our country. And you're probably not going to be able to see this. Hang on. So here you see the breakdown of poverty numbers in the United States. So what I'm just showing this to you. What does it mean? Like, how do you quantify poverty? So it depends on how many people live in the house. So think about an older adult, maybe it's that older Latina woman. She lives alone, and so one person in her household, and if she makes $12,490 or less, she's considered in poverty. That's not a lot of money. So that's just about $1,000 a month. As you have more and more people living in a household, the poverty level increases, but that's just because there's more earning potential within the household. Or you have children who are in the household. So maybe you have 4 people and 3 of them are children. This or less considered poverty level. Again, not very much money for 4 people in a household. So just wanted to show you that. Alaska is a little different, and Hawaii is a little different. And the reason that those are separated out is because the cost of living in those states is very high. And people tend to make more money as well. Back to the PowerPoint. So a few extra terminology terms here. We call people who are 90 to 99 non-agenarians, and probably the most famous person in the world who is a non-agenarian and has aged pretty well is the Queen of the United Kingdom, Queen Elizabeth II, longest reigning monarch in British history, you know, all that stuff. But how old is she now? I think she's 94, 95. And then her husband, I think, is 99 years old. So they are both non-agenarians, and her husband is about to become a centenarian. So a centenarian is a person who is 100 or older. Currently in our country, about 100,000 people are 100 and older. That's expected to grow by 6-fold within the next 30 years or so. People are living longer and longer. The vast majority of people who are 100 and older are female, and you would guess that because, you know, women live longer than men. And many of these people are aging well and are very much cognitively intact with no evidence of dementia. The baby boomer generation are people in the United States who were born between 1946 and 1964. And that's easy to remember, isn't it? Because 64, invert that, 46. And so 1946 to 1964. In 1946, there were 3.4 million people born. And then every year after that occurred, all those people being born, 3 to 4 million people every year until about 1964. That's a lot of people being born. The baby boomer generation started turning 65 in 2011. So for about 9 years, this population, or this cohort generation, has been turning 65. So it's a lot of people. You can do the math for that. And how old is the oldest baby boomer? Speaking of or about minorities who are older adults, African Americans in our country in 2014, about 10% of the older adult population, but we expect that as well to grow. We expect all of the racial groups to grow in general because the population of older adults is growing overall. Hispanic, about 3.6 million, it's probably more than that now because these numbers are old, but again, I'm trying to keep these updated, but still a little bit of old data from the government. About 10% of the population, and that's expected to grow very high by the next 50 years or so, and be over 22% of the older adult population. So that's expected to double. No, not double. Quite more than that if you look at the numbers. Asian Americans, lower percentage of the older adult population, but also expected to grow as well. So it says, what factors would change the demographics of older people related to these things? I've mentioned some of these. I think maybe all of them, but a lot of it is just numbers. People living longer. Women live longer than men. Women in older adulthood are more likely to be widowed. Also, if you have older men, maybe who had a spouse who passed away, the older man is more likely to remarry in older adulthood than older women. And they may often do this soon after the death of a spouse, and sometimes this upsets families, but it's a common phenomenon, and we expect that to happen often. So that's a difference that you may see with marital status of older adults, men versus women. I already mentioned that older women are more likely to live alone, but some groups of people may be more likely than others to have their older parents, their grandparents, to live with them and to live as a family. So that may be a cultural thing. Older adults may be, and like I said, in higher rates of poverty as well. This is a graph here. We actually call this a histogram, or whatever you want to call it. But this is just a graph showing you some differences in life expectancy between, it's very focused here, but it's between white and black people compared to all races. So take a look at this, and when you see something like this, you would want to take a look at it and see if you see anything that stands out to you, any differences. So take a minute and just look at it and see if anything stands out to you. What I notice when I look at this is that I look here at the right side over female, And I see that women live longer than men, so that should stand out to you. Also, I notice that it says here that older white females live longer than older black females. And I'm looking over here at men, and I notice a huge difference somewhere. I'm seeing a huge difference of older black men compared to older white women. That's an entire decade of difference in life expectancy. Older black men have the shortest, or excuse me, black men have the shortest life expectancy in our country, that group of people. It's a full decade different than white women in our country who have the, in this graph, the longest life expectancy. So someone may ask, why is that? And an answer might be, well, it's genetic. A decade of life expectancy difference is more than genetics. There are lots of social issues and disparities in our country that contribute to that. So just maybe think of some things that may contribute to that. All right, I'm going to show you a little bit more about life expectancy. I'm just going to scroll down to these tables. Yeah. So it's a little more detailed here. So you could go through and take a look and say, when this was published, 2017, a few years ago, that a person at age 0, so at birth, you could see what the life expectancy was for that person, right? So overall, in the United States in 2017, if a person was born in 2017, that person, if it was a male, he was projected to live until about 76. Female, around 81. That's overall though. But then if you come in and look at differences between races, then you can see some of the, again, these disparities popping out. It's beginning to close a little bit, but look at the differences here. Again, we're still seeing the black male around 72 years compared to the white female around 81 years. So a little bit of closing there, but not much. And then we can look on over here and we say, well, who has the longest life expectancy in this graph? So we could say, well, it's probably going to be a woman, right? Female. So 78, 81. Oh, okay, well, that's pretty high. 84, 84.3. So I would conclude from this that a person born in 2017 who has the longest life expectancy per this would be a female Hispanic person. Interesting, huh? So in 2017, if a person was 70 years old, these numbers are going to look a little different. What this is saying is that we're projecting that they have about 14 and a half more years to live after this year. So that would be what, 84.5. Anyway, just want to show you that. I thought that this graph is interesting. So if you like, take some time later to look at it more closely. Get back to the PowerPoint. Where to go? There we go. So who's going to care? Who's going to care for these people? Who does care for these people? The older adult population is growing very quickly. Well, you are nurses, right? So you think, well, I'm not going to be a gerontological nurse. Well, yes, you are. Every nurse really is a gerontological nurse. You will care for older adults in almost every setting that you work. And so what we are, some goals for healthcare, goals for nurses, goals for the society is for us to be better prepared to care for older adults because our society is aging. So that's why we have increased the education to healthcare professionals on caring for older adults. And you're getting it right now. And honestly, having a standalone gerontological nursing course is still uncommon. I don't know the exact percentage, but I would guess around 20, I think it's around 25% of programs of nursing in our country have a standalone gerontological course. Most programs would say that they integrate the gerontological nursing aspects into their other courses, but often that's not done very well. And gero, our older adults, are kind of an afterthought often. But when older adults should not be an afterthought. They should be a forethought because they are largely the people, the population that we care for. We have lots of older adults in our country who live in a facility, like a nursing home, assisted living, and things like that. And as we have more and more facilities and more people living in those places, we're encountering more issues with staffing. And also, it's not just the number of people there to care for those people, it's the level of their education. So it says here, particularly professional nurses. And what that means is RNs. RNs are considered professional nurses. And that is because, and we need more RNs caring for older adults because RNs are better prepared to do so in general. Just a quick look here, a few numbers in that the large majority of people with cancer are older adults. Has anyone ever been maybe to a cardiologist or a oncology office? You sit in the waiting room and you look around, who are you seeing? People who look older, most likely. Also, a good percentage of people who visit urologists. Older adults have more genitourinary problems than younger people. So what are some different types of roles for nurses in caring for older adults? Well, just in general, hospital, you're going to care for older adults. Older adults receive care in all types of settings. Also, we have advanced practice nurses, like nurse practitioners, CRNAs, who care for older adults in big numbers as well. We used to have this advanced practice or nurse practitioner certification called a gerontological nurse practitioner or geriatric nurse practitioner. That doesn't exist anymore. Some people may still be certified, but no one is newly certified there any longer. They have integrated all of that stuff into the family nurse practitioner programs and also the adult gerontological nurse practitioner programs. Anyway, that was just a recent shift in our profession recently. Our goal for older adults is to preserve what function that they have, enhance what they can do, maintain their health, manage their chronic conditions. And also, we do a lot of research on older adults, and nurses play a big role in that as well, either by conducting the research or assisting with the research. These are the topics that are most commonly researched in older adults. Some of the stuff gets overdone, if you will. Like, for instance, I'm tired of hearing about falls. You know, we know how to prevent falls. We need to stop researching it. We just need to prevent the falls. We have done a lot of research on older adults and restraints, and I will talk more about that topic later in the semester, but restraints really don't protect older adults, and we know that by the research. We should do our best to not use restraints, especially in the older adult population. And we've done a good bit of research on that, and therefore, like I said, we need to implement that practice. This is just a quick overview of these things. Not a huge deal here, but the AACN, which is the American Association of Colleges of Nursing, has laid out several years ago the geriatric or older adult competencies that should be included in RN programs. We have also the essentials for BSN education through the AACN as well, just an outline of what should be included in BSN education. So those essentials for BSN don't specifically talk to the older adult content, and that's why there are the geriatric competencies. So that's just the content that should be included in nursing programs. Okay, I'm going to take a break now. All right, so chapter 2 is mostly about disease prevention, talking about health and wellness, and it will be a brief one. I think you know the difference between health and wellness. Health is a more simple term to mean that a person is not sick, that they don't have a certain disease. But most older adults are not technically healthy because most older adults have some sort of chronic condition that is managed. So we look at the wellness of a person, right? We look at their wellness status, and wellness can include physical health, emotional, so all these different aspects of a person incorporated defines their overall wellness. So that's how we think, especially about older adults. This is just a visual here to show that there are many components to an older adult that promote healthy aging, and biological just being one component of that. Quickly about Healthy People 2020. It is 2020 now, so we are evaluating if we met all of our Healthy People 2020 goals. I'm sure that we haven't. We never always meet those goals, but the thing about Healthy People 2020 was that it was the first time that older adults were explicitly mentioned in those goals, which was definitely a step forward, because we know that we have a large percentage of our population who are older adults. And so we should directly focus on improving the health and wellness of that population. Let's review a little bit about prevention. I realized that Dr. Hoffman talked in detail last semester with you about different types of prevention. So let's just review a little bit. Primary prevention is preventing things from occurring before they occur. And this can be not just physical things, but thinking about cognitive health for older adults as well. So think of an example maybe of cognitive stimulation that is healthy for an older adult. Well, lots of things. It could be the socialization increases cognitive health. Keeping the brain active stimulates cognitive health. Keeping a person with lower stress as well improves cognitive health. So also healthy lifestyle behaviors, appropriate diet, appropriate exercise. Those are primary prevention strategies. Remember also that immunizations are primary prevention. We are entering the flu vaccine season, and we will soon be in flu season. I hope it's not too bad with the pandemic, but so we need to highly encourage all people, unless contraindicated, to get a flu vaccine, especially this year. Older adults included, so older adults actually get a different flu vaccine than people who are younger. So people who are below the age of 65 get a standard flu vaccine, and it has a 15 micrograms, if you will, of the vaccine in it. The hemoglobin is what we call it. So the older adult gets what we call high-dose flu vaccine. When you're looking at the flu vaccine, if you will, you'll know that it's high dose if it has HD in it. And also in the title, it might just spell out high dose. So, for instance, if you had like Fluzone, it would be Fluzone HD. You might think high definition, but it's high dose. People who are 65 and older should get the high dose flu vaccine. And the reason for that is because older adults' immune system isn't as effective as people who are younger. The older adult's immune system doesn't build antibodies as easily as a person who is younger. So we give them more vaccine to stimulate a better response so that they do build those antibodies. Secondary prevention strategies are things to identify if there are issues occurring so that we can intervene to prevent them from being a problem or prevent them from causing other problems. Just getting labs drawn, checking a person's thyroid is secondary prevention. So it helps to identify. So that is a common secondary screening for older adults, a thyroid function test. It is a very common problem in older adults, especially hypothyroidism. So be thinking about the differences between primary, secondary, but also tertiary prevention. Remember that tertiary prevention is essentially treatment. So if a person has diabetes, then the diet plan is a tertiary prevention strategy. Their medication is tertiary prevention strategy. And that's chapter 2. Chapter 3 is about theories of aging. And I know how much nursing students love to hear about theories. But what I have done with these slides is tried to make them very focused, and so that you can maybe see how to attach theory to practice. A few terms before we get into different types of theories of aging. Senescence is defined here for you. It's the deterioration with age. And this happens to all the cells in our body. We have cellular functioning. All of our, the majority of our cells will replicate and turn over and renew. But as a person ages, that process can change, and then the cells and the DNA can get damaged with multiple cycles of replication. We have some ideas of programmed aging, and that's just what it sounds like. We have some ideas of errors that occur, which I kind of just mentioned in the cellular function and replication process, that are cause some of the aging. Our DNA has telomeres, right? Our chromosomes have telomeres, which are like little end caps on those telomeres, on those chromosomes that are protective. So I think of them kind of like the bumpers, or just protective caps, if you will. So those telomeres shorten with every cell division, and there are some theories or hypotheses that this contributes to the breakdown or aging of our cells. So the older the cells are, the shorter the telomeres become, and they're less protected, if you will, and that senescence happens more. We have some theories that are called programmed theories, and in general, these point toward that there is some sort of biological clock. These are some examples of programmed aging theories: neuroendocrine control, pacemaker theory, and immunity theory. And I'll get more into those. Overall here, the neuroendocrine or pacemaker control is that theory here is that it is designed, our bodies are designed to age, and that we are kind of pre-programmed. And that focuses on how the immune system, the nervous system, and the endocrine systems age. The immunity theory is again a programmed theory. It's more specific. We have this term of, computer's doing weird being weird. Immunosenescence, so that breakdown of the immune cells. They don't function as well. They are produced more slowly in the older adult. All right. We also have some theories that are related to error. These are called like wear and tear, cross-linkage, oxidative stress, or the free radical theories of aging. These are error theories, like I said, so we would say that these are not predictable, and the theory here is that it's not connected to a clock or to be pre-programmed. It's that errors occur and then cause issues with, or just cause symptoms of aging. The wear and tear theory is just what it means, that the cells or the parts of the body wear out just because of use, because of multiple cell replications. And this can be internal or external. Stressors can contribute to the wear and tear. The cross-linkage theory of aging is that the proteins within cells get cross-linked, and that causes damage to the cells. For instance, the cellular glucose attaches to protein, and therefore the blood glucose isn't as stable. The production of glucose in the body is not as effective. That's the glucogenesis also, in the liver. Also, the cross-linked proteins can cause changes in the collagen, and that's where we see a lot of the changes to, like the skin with wrinkles and sagging and thinning. And remember that the collagen is not only in skin, but it's in many, many parts of our bodies. So think about the arteries, and you think about collagen being lost in the arteries, and that can cause the stiffening of the arteries, which can then lead to hypertension. The free radical theory, or oxidative stress theory, is that this is more of an external things that we have, we're exposed to free radicals, and that can cause cellular damage. One thing with this is that we have antioxidants that we can take in, and this can help to combat the aging. So free radicals cause damage. They can lead to cancer. It can damage all types or all parts of the body. The mitochondrial DNA in our body is greatly affected by free radicals. So antioxidants can help to neutralize free radicals in the body. It's kind of a lifelong thing, though. We should take in a good amount of antioxidants throughout our lifetime to prevent or stay off some of the symptoms and signs of aging. And it's not just an intervention to implement as a person becomes an older adult. So this is a little video on aging, and I think it's neat, and the narrator does probably a better job of explaining some of these things than I did. So let me play this video for you. Let me share the screen with you.
In 1997, a French woman named Jeanne Calment passed away after 122 years and 164 days on this earth, making her the oldest known person in history. Her age was so astounding that a millionaire pledged $1 million to anyone who could break her record. But in reality, living to this age or beyond is a feat that very few, maybe even no humans, are likely to accomplish. Human bodies just aren't built for extreme aging. Our capacity is set at about 90 years. But what does aging really mean? And how does it counteract the body's efforts to stay alive? We know intuitively what it means to age. For some, it means growing up, while for others, it's growing old. Yet finding a strict scientific definition of aging is a challenge. What we can say is that aging occurs when intrinsic processes and interactions with the environment, like sunlight and toxins in the air, water, and our diets, cause changes in the structure and function of the body's molecules and cells. Those changes in turn drive their decline and subsequently the failure of the whole organism. The exact mechanisms of aging are poorly understood, but recently scientists have identified 9 physiological traits, ranging from genetic changes to alterations in a cell's regenerative ability, that play a central role. Firstly, as the years pass, our bodies accumulate genetic damage in the form of DNA lesions. These occur naturally when the body's DNA replicates, but also in non-dividing cells. Organelles called mitochondria are especially prone to this damage. Mitochondria produce adenosine triphosphate, or ATP, the main energy source for all cellular processes. Plus, mitochondria regulate many different cell activities and play an important role in programmed cell death. If mitochondrial function declines, then cells, and later on whole organs, deteriorate too. Other changes are known to occur in the expression patterns of genes, also known as epigenetic alterations, that affect the body's tissues and cells. Genes silenced or expressed only at low levels in newborns become prominent in older people, leading to the development of degenerative diseases like Alzheimer's, which accelerate aging. Even if we could avoid all these harmful genetic alterations, not even our own cells could save us. The fact remains that cellular regeneration, the very stuff of life, declines as we age. The DNA in our cells is packaged within chromosomes, each of which has 2 protective regions at the extremities called telomeres. Those shorten every time cells replicate. When telomeres become too short, cells stop replicating and die, slowing the body's ability to renew itself. With age, cells increasingly grow senescent too, a process that halts the cell cycle in times of risk, like when cancer cells are proliferating. But the response also kicks in more as we age, halting cell growth and cutting short their ability to replicate. Aging also involves stem cells that reside in many tissues and have the property of dividing without limits to replenish other cells. As we get older, stem cells decrease in number and tend to lose their regenerative potential, affecting tissue renewal and maintenance of our organs' original functions. Other changes revolve around cells' ability to function properly. As they age, they stop being able to do quality control on proteins, causing the accumulation of damaged and potentially toxic nutrients, leading to excessive metabolic activity that could be fatal for them. Intercellular communication also slows, ultimately undermining the body's functional ability. There's a lot we don't yet understand about aging. Ultimately, does longer life as we know it come down to diet, exercise, medicine, or something else? Will future technologies like cell-repairing nanobots or gene therapy artificially extend our years? And do we want to live longer than we already do? Starting with 122 years as inspiration, there's no telling where our curiosity might take us.
Okay, so I've enjoyed that video. Let me check here's a few questions. All right. Get back into the PowerPoint. So these are some more theories of aging, psychosocial theories of aging. And what I did here is just briefly stated what the idea of the theory is, and then how the person we would know that maybe they're successfully aging. So for instance, we have the role psychosocial theory, in that we say that older adults may need to adapt to different roles as they age. And we would say that the older adult who is successfully aging can adapt to these new roles appropriately without resistance or major stress in their life. The activity theory of aging is that the older adult should maintain a productive physical and mental life. And if not, then we would say that they're not successfully aging based on activity theory. So if the older adult becomes much more stagnant or less mobile, bedridden, they're probably not meeting this outcome related to activity theory. Disengagement theory is that the older adult, we would expect them to disengage from parts of their life. Maybe it would be disengagement from a role, like I mentioned before, but saying that the older adult should be able to, in a positive fashion, transfer things to younger generations. But if the older adult is unable or is comfortably to do that or has trouble with that, then we would say maybe they're not successfully aging with disengagement. Some people, it says now considered controversial, but some people consider this controversial and that are not subscribed to it, if you will. Continuity theory of aging is that the older adult should maintain certain things throughout their lifetime, particularly things that they enjoy. We think about maybe continuing to be social, continuing to be part of a group or a professional organization, and they can maintain that through their older adulthood, and that means successful aging based on that. Just in general here with age stratification, that older adults of a cohort or a generation, knowing that those people who are around the same age experienced things in their past together, they age together, they have the most similarities to each other when you're closer in age. So we know that if older adults have a group of a social group of people who are similar to them and who are similar in age specifically, that age stratification is positive for them. So maintaining relationships with people who are similar to them. Not meaning that that should be the only types of relationships, but it's important to have relationships with people who are like you, and that's for all ages, really. Modernization theory of aging is that older people may lose status in society or have a hard time at a job or whatnot because of technology, and that technology could push out older adults who may be resistant to technology changes. But this is also challenged and not always subscribed to this theory because older adults can learn new technologies, and we know that. Developmental theories, you probably are familiar with these already. I won't spend a lot of time on them. You probably have heard of Erikson many times when preparing for nursing school and in nursing school courses. But the phase of Erikson's theory that mentions older adults is the ego integrity versus despair. The initial part of when Erikson first developed these stages, it was kind of stringent and strict, but as he aged and later in his life, he adjusted his theories and said it was more of a balance, that, you know, it's not so clear-cut, if you will, but that ego integrity versus despair is the phase that older adults are in per Erikson. Also, there is the theorist Peck. He was, if you will, a student of Erikson's, and he expanded that final stage, the ego differentiation versus work role perception. Also added the body transcendence versus body preoccupation, ego transcendence versus ego preoccupation. So those were expanded out of, if you will, the ego integrity versus despair. Jung, the theorist, looked at extroversion versus introversion, focusing more on a personal meaning of life, spirituality, that the older adult may be better able to search and to find their true self. And I'll talk more about kind of that concept later in the semester when we talk about transcendence and gerotranscendence. Of course, you know Maslow. We have Maslow's hierarchy of needs, very much focused on in nursing when we are prioritizing things for our patients and clients. Older adults would need the same needs as any other population. Physiological is the most important, safety, and then moving up that hierarchy. So as you step up that hierarchy, the previous is a prerequisite to moving ahead. Tornsom is similar to Jung about gerotranscendence, and it's about inner reflection, spirituality, that the older adult has the better ability to look within and whatnot. Talk more about that later again. So taking a look in your textbook about in chapter 3, there are some boxes in that chapter that outlines some more interventions for you that are theoretically based. So please take a look at that. Theory-based interventions. Not going to just read this slide to you, but take a look at your textbook and think of things how we could apply theory to practice and also maybe applying theory to test taking. So it focuses on, especially with Maslow, prioritization. And then you could start with Maslow, looking at those high priority needs and then matching those to the different types of aging theories. So thinking of the priority of physiological, then you would maybe turn toward the biological theories, and we could use those theories to guide practice to meet the physiological needs of a person. And then moving up to, you know, self-actualization, we certainly would need to look into the psychosocial theories of aging. So let's see, I'm not sure what this next slide is. Okay. This is a video, and I don't think I'm going to do this in class here on Zoom, but I do encourage you to take a look at this video. It is 13 minutes long, so that's why I don't want to show it in class, but I encourage you to watch it outside of class and just let it stimulate some thinking or ideas about aging as you hear people who are 100 years old or older speak. All right. Okay, so back to this, and that talking about culture and whatnot, not being able to generalize things, having cultural awareness. I like also the term cultural sensitivity, and the way that I like to practice that is, for the most part, letting the patient take the lead, allowing them to show you and tell you or act and behave, showing you how they want to be treated, so really letting the patient take the lead and having some cultural knowledge and being aware and sensitive, I think is very important. Please be sure that your microphone is muted. I've kind of already talked about the gerontological explosion and how the population is growing of older adults, and how some of those, if we will, minority groups are also growing in the United States. And really, there's been a lot of talk about this with regard to culture and whatnot in our society, that we need to do away with the term minority, and it's just different groups of people. And that when we think of minority, we think of smaller groups, but traditionally minority groups are growing. And so anyway, the term minority and majority in our society is becoming obsolete, just FYI, and you probably already know that. Several semesters ago, a student asked a question in class, and she said, when you're talking about minorities and talking about how certain groups have a higher rate of maybe hypertension, and then she said, who are you comparing that to? And I thought, well, that's really a good question. We always just say those things, but it's the minority groups, if you will, being compared to the majority in our country, and of course that would be people who are white. So that's the comparison. So looking here again, just a little bit about the population due to age, and the population with regard to age and aging in the United States. So within over the past several decades, we have seen and are still seeing much growth of minority groups compared to white people. So looking here at the African American population, since around 1990 and to almost now, within the next 10 years, 131% growth of the African American population. Looking at Asian people, look at that percentage, and also Hispanic or Latino. And the group with the least growth is our white people. So the majority is growing less fast than minority groups, and we're seeing that, and that's one illustration there of how minority groups are really becoming no longer minority groups. Health disparities for older adults. We think about barriers to care, and it may not be only a barrier to simply accessing care. It's also, we think about barriers to accessing good care, quality care, and that could simply be where a person lives. And a person who is younger, if they live far away from a healthcare provider, may have an easier time getting there. So different factors are related to people that can create health disparities, access to care, comfortableness with receiving care, and one of those major things is age. Here are some examples of major health disparities in our country. And the reason that I mention these things is because older adults are the people who most likely and most commonly experience these issues. So take a look over here on the left side, and everything on the left side here of this slide is referring to African Americans. 50% more likely to have a stroke. Wow. And that is related to the higher rate of heart disease, hypertension in the African American population. I think you probably know what a transient ischemic attack is, or a TIA. Some people call these mini strokes, but a TIA is a temporary blockage of a vessel or artery in the brain that causes symptoms, but then resolves within 24 hours. So it's a temporary stroke, transient ischemic attack, TIA. If a person has a TIA, they are at a very high risk now of having an actual stroke. So we would need to anticoagulate those people. But African Americans are 62% less likely to get anticoagulation after a TIA. So that's going to lead to more strokes in this population. Also, if an African American has a stroke, they are 50% more likely to die And that's because of mainly access to quality care. Or we have conscious and unconscious biases, even healthcare professionals do, and we have to keep those things in check so that we treat everyone with high quality care. 1.5 times more likely to have high blood pressure, diabetes, 2.5% more, 30% more likely to have amputations related to diabetes than the white population. So, and people will often ask, well, why is this? Why does this happen? Well, and many times people will just blame it on genetics, right? Well, I'm tired of that. I'm tired of blaming health disparities on genetics. Now, there is a genetic component to many things, but I think in our United States culture that we love to just blame things on genetics. And anyway, like I said, I'm tired of it. So it is, many of these disparities come out of biases and injustices and racism that is ingrained in our United States culture, and we have a lot of work to do to close these health disparities. And as nurses and healthcare professionals, we are given the opportunity and are expected to address this, and we are. Mexican Americans specifically 2 times more likely to have diabetes, and also 36% fewer prescriptions after a heart attack. After a heart attack, I guarantee the person's going to walk out of that hospital with a lot new medications or adjusted medications, keeping blood pressure in check, putting the person probably on an ACE inhibitor, putting them on a beta blocker. That's going to help prevent complications from the heart attack, and often the Mexican American doesn't get that. It could be the access to care. It could be a language barrier. Lots of factors are in play here. Insurance status. So, Native Americans. This is extremely high. Almost 6 times more likely to have diabetes than white people in the United States. And when I see something so profound as that, you think, well, there has to be some sort of genetic component in addition to major social components in our country. So I think that perhaps the high diabetes rate also in this population could also be related to a higher rate of also alcoholism in Native Americans, and that, you know, not going to get into the genetics about that, but that connection between misuse of alcohol and diabetes, there is a correlation there as well. So I'm not going to dig much deeper than that, but just pointing these things out to you so that you can see the disparities of health in these groups. Pick these out because they are huge problems. And again, that the older adult is going to be the one often that you see these things happening to, because generally as we are older adults, that's when these problems happen to us. But they happen in younger adults as well. To reduce health disparities, we have to focus on cultural awareness. Kind of already mentioned that. Cultural sensitivity, cultural knowledge, and recognizing that culture brings along with it beliefs about healthcare. It brings along differing levels of trust of healthcare and healthcare professionals. So being sensitive, listening, asking questions, having first a self level of understanding of your own experiences and beliefs and values, and your ability as a nurse to work with older adults and to understand older adults, and that they may often have different ideas and beliefs about the world than you do, and accepting that and working with them to get a good outcome. I've already mentioned that cultural knowledge is really the knowledge of the nurse and what the nurse brings to the situation, and also in addition to that, what the nurse learns about the older adult and that person's culture and their attitudes and beliefs and experiences in the world, and how that relates to their health and can create health disparities. And understanding that and knowing those things can help us close the gaps. A few more things here. Culture, yeah, I think I've already defined that on the first slide of this section, but it's the shared and learned beliefs within a group, behaviors, expectations, experiences, ideas. Acculturation is when a person of a minority group or a minority culture is adopting attributes of the majority culture that is around them. To a degree, some acculturation is not negative, but often acculturation can be forced on people, like a person forced to learn a language or forced to dress a certain way or pay the consequences. That's negative acculturation. And then ethnicity is different than race, which I'm sure you're aware of. So a little more about older adults with health disparities. So thinking about older adults, they may have a higher rate of ideas about health that are not mainstream, if you will. So the most mainstream thing, of course, is the Western medical paradigm, the beliefs about health and wellness and treatment, and that's you know, in general, you know, like think about the United States. We're very much, for the most part, biomedical beliefs about healthcare, where we focus on disease and alterations, and we treat with medication and whatnot. But within also our United States culture, you know, and varying cultures within the United States, we are very diverse, obviously. And we have one thing that many people, especially older adults, may subscribe to, is the magico-religious thoughts about health, in that that a supernatural being or a god or a higher power or force, whatever that person believes, that that their health may be granted to them as a blessing, or that they are rewarded with good health because they did good things in life, that they please their God, and that being a good person and pleasing God and living the life that they think is correct per their religious beliefs, that that's how they stay away from disease and illness. Additionally, we have kind of a naturalistic or holistic thought that some people may have, often, again, older adults, that health may be a sign of balance in a person's life. And when a person is sick, then there must be some sort of disharmony within them that is treated in a more naturalistic fashion or whatnot. And I think this kind of ideas are becoming more and more common throughout different ages in the United States. And I think a common one now is like the essential oils and whatnot are very popular. And that kind of falls into this naturalistic. Some obstacles related to health disparities that I think it's a common phenomenon in our United States, that people often tend to be egocentric, ethnocentric, thinking that their ideas and about the world are superior or the only ones that matter, and this can marginalize people. So, for instance, if the older adult really believes in the religious component of health, and then someone would just contradict that and say you're stupid for thinking that health is simply biological, that would be an act of ethnocentrism. I've certainly seen it happen in healthcare. So as nurses, we have to be careful in the way that we respond to people, because our beliefs are going to be different than a lot of people that we care for, and you may not connect as well, especially with older adults, as you're caring for them, but you have to make a concerted or conscious effort to do so. Stereotyping. There's a lot of stereotypes about older adults, right? So we should keep that in check and not allow stereotypes that we've heard. We should not allow the stereotypes or those unconscious biases to affect the way that we are treating people, both socially, but healthcare wise. So thinking about ageism, can anyone think of some examples of ageism or stereotypes about older adults? If you don't mind, I can't see the chat right now because the screen is being shared. I'll just leave it that way. If you don't mind just saying, if anybody has any ideas about that, just speaking to the mic. I'll start it off. Older adults can't hear. Go ahead. All right, well, I'm going to come out of this and I'm going to start. Hang on. So I've already talked about reducing health disparities within or in the older adult population, but having those cultural skills, kind of went through that already. But also be careful with communication and how communication can create disparities. And remember, communication, not all of it is the words that we say, it's maybe how we say the words. It could be nonverbal communication like body language, positioning, rudeness like eye rolling, and even like subtle things that we may do unconsciously, or subconsciously. Unconscious means that you're asleep, but anyway, it's subconscious. So you know what the word jargon means, I think, but that's like terminology. So using a lot of maybe healthcare terminology when talking with people, that's going to create disparities because they're just often may not know what you're talking about. Also, you know, it can be the tone that we use in our voice. It could be the inflection that we use in our voice that can create negative communication, which can create health disparities. So thinking about disparities still in communication, so think about some of these unspoken types of communication and what it can tell us. So thinking about silence. If you are speaking maybe with an older adult, and that older adult is just silent the whole time that you're trying to teach them about their new diagnosis of diabetes, that should tell you something. It may mean that they aren't understanding. It may mean that their belief is that they should never question a healthcare professional and just believe everything that they say, or not contradict or whatever, and then they might just still go home and do whatever they want to do. So understanding that different types of unspoken communication can give us a lot of information. So are they comfortable with eye contact? Are they not comfortable with it? Are they extending their hand for a handshake? Are they comfortable with that? So that can give you some information about the person's level of comfort as well. So and then sort of similarly, spoken communication and how that can give us some information as well. So obviously, if the person doesn't speak the language of the nurse, then there needs to be an interpreter involved. And remember that an official interpreter is always best to deal with differences in languages in healthcare. If a person is not in the house, if you will, at the facility to interpret for you with a patient, then you remember what the blue phone is, right? So the translator phone, and so we can use that to communicate with patients. All right. So review your textbook. I think let me make sure that got updated. Looking at chapter 4, box 10. A little bit about gender in older adults and how that is part of, obviously, culture. Again, we have more and more older women as a population, or a cohort, if you will, grows. And so then we would need to look at and understand some of the characteristics of the older female population. We know, again, that in social settings that older women are more likely to live alone. I've already mentioned that older Women of color have maybe higher social status within a family, more of a matriarchal family unit, perhaps. And older women may have a broader and better social network than older men. We know that often older women have higher rates of poverty than older men, so having that understanding is important. Also about older women, that historically healthcare research was not done on older women as it should have been. But then we had several years ago this initiative called the Women's Health Initiative, where we promoted and actively enrolled older women and women in general of all ages in research studies for healthcare. And then we discovered a lot of stuff. Like, for instance, out of that, we learned a lot about heart disease and symptoms even of heart attacks present often differently in women than in men. So you can see how obviously that could create some health disparities. Older women may have relied on their spouse's health insurance. So, you know, in the United States, at 65, everyone's eligible for Medicare. However, Medicare is not wonderful. It doesn't pay for everything. So any supplemental plans may have been held by a person's spouse, and if that spouse passes away, then they may lose that. So, and then looking at older men. So because we did have the Women's Health Initiative, and it actually has turned research often more toward focusing on the aging concepts of women, and there is becoming now less literature and research done on older women than older men. All right. Oh, already mentioned African American men have the shortest life expectancy and lifespan, only living on average, looking at lifespan or life expectancy into the early 70s. And because we think about older women having higher rates of poverty, we may overlook that older men still are at risk for having lower socioeconomic status in society. And we may assume that an older man has enough resources when it may not be the case. So therefore that creates a sort of stereotype. So this is a graph showing the median earnings by age and sex, and this is for for an employed full-time over 12 months. So looking here, males versus females, and how that changes. So you do see that kind of as a person becomes an older adult, they may begin to make less money, especially women. So looking at the lighter purple bar there, that women overall in all age groups we know make less than men do. But looking how that bar, so looking at the purple bar, so the top, all workers 16 and older, 65 and older, those are about the same. But as we go down to older women who are 75 and 85 and older, that income slowly decreases, when actually we see a little bit of a boost in older men's income at 85 and older, even compared to 75 and 84. I can't exactly explain why that happens, but why older men 85 and older make more than older men who were 75 to 84. I don't know the answer to that, but there probably is. So I just wanted to show the discrepancy here and how that imbalance, the pay disparity between men and women, becomes more profound with age often. Okay. So thinking about the nursing assessment and applying cultural concepts, understanding how to do that, and I've already talked through some of that, but take a look at box 414 in your textbook, and it outlines some interventions to follow when to promote a culturally competent encounter with the patient, and speaking here to older adults. So one thing that I like to tell students when having an encounter with an older adult is that please sit down with them. Sitting with them level, eye to eye, it promotes communication for several reasons. It physically puts you on the same level, therefore it's more of a personable interaction. And also, standing over a person can be a more authoritative stance. In healthcare, we're bad about standing over people, and it happens, I feel, more with older adults. So be aware of that. Sit down when talking with an older adult in a healthcare setting. But take a look at those other things like listening, making sure that you're picking up on subtle cues, verbal, nonverbals, that you are asking questions. So if you know that a person maybe has a culture that is very different either from yours or just from our country, they could be a visitor from another country, and asking them questions. Well, what do you think is wrong with you today? Why do you think that this happened? So getting an understanding of their beliefs and ideas can help us solve their problems. Kind of already mentioned this, looking at that box in your textbook as well, but understanding that in general that when making a goal with patients that it needs to be mutually agreed upon, that they agree to follow what you taught them to do. And with older adults, this aspect is even more important. So we want to make sure that they're understanding our teaching, making sure that they agree with the plan of care. Older adults can often be more likely than younger people to go home and after we've given them all this teaching and then not follow it. So because they didn't agree with it, but maybe we didn't ask them if they agreed, and we're unable, and we missed that opportunity to individualize their plan of care. So implications for this, again, the LEARN model, and that's just an acronym for listen, explain, acknowledge, recommend, and negotiate. Don't necessarily need to memorize this slide, but just in your practice be aware that these things, that listen, explain, acknowledge, recommend, negotiate, are important for you to develop individualized care for the older adult and to promote their health and healing. This is an interesting idea here, and I think that your textbook speaks to this as well, but we have this on-look program or model, making sure that we provide resources for people who are of varying cultures, ethnicities, faiths, beliefs, whatever, and that we have different things available for different types of people so that we can support and reflect the diversity of our older adult populations. This model even looks to consciously make sure that people are surrounded by people that are like them, going to even an extreme of suggesting maybe a monocultural facility, which may sound controversial, and perhaps it is, I don't know. Because then I would think about exclusion, and we wanted to when we think about inclusion. But it's focused on really making people comfortable and providing for them what they need. So that is the lecture on those topics. So that's all the content that I have for you. If you'll give me just a minute, if you want to take just a few minutes break, we'll come back in 5 minutes and we'll do some practice questions together and answer any questions you have.